Hello, I'm J. Michael Bennett. Today we're going to talk about the shoulder. As a sports medicine physician, there are common elements that we see in shoulder pathology. And today I want to just discuss a few of our common injuries that we see in a lot of our contact athletes regarding upper extremity or shoulder injuries. This here is a model of a shoulder joint. Just going over some of the basic anatomy of a shoulder joint, you have two primary bony structures that make up the shoulder girdle. The primary structures, three structures that make up the shoulder girdle. The primary structures are their clavicle, which is this bony plate-like bone here, which attaches to the clavicle, which is this long bone here in the front of the shoulder. And all of this articulates with the humeral head, which is a ball-shaped bone. Now the ball-shaped bone here articulates within this joint with a cup that you can see right here. So we call this the ball and socket mechanism. So shoulder motion occurs through this ball and socket mechanism, and then it transfers through the scapula-thoracic mechanism. So the scapula-thoracic joint is this scapula that articulates with the rib cage right here, and that's the scapular-thoracic joint. Okay, so the first type of injury that we'll discuss today are fractures. And one of the common fractures that we see in the clinic is usually what's called a clavicle fracture. And this is the clavicle bone that comes across, and you'll usually see this in most patients up at the front of the shoulder, also known as the collarbone. And this usually occurs from a direct impact onto the side of the shoulder, and the forces are transmitted to this bone, and you'll get a shattered clavicle. Sometimes it could be in 3 or 4 pieces, sometimes in 2 pieces. The most common place to see a clavicle fracture is in the mid-shaft. Depending on how displaced that clavicle is, how young the patient is, and what their athletic endeavors are, how quick they want to return to play, is going to be taken in consideration when discussing treatment options. One option is to treat this non-operatively with a sling, and the majority of these can be treated that way, and the majority of them will heal, as long as there's not significant displacement amongst these fracture fragments. The other option is putting a plate on this clavicle, and we have special contoured plates that actually fit exactly the shape of the clavicle with some very low profile screws that hold that clavicle in position. This actually gives you a stable construct, and for some of our elite athletes and high contact athletes, we typically would fix these if it's significantly displaced or if they wanted a quicker return to function. So as always, do your due diligence in picking your surgeon, discuss your surgical options, and never ever hesitate in asking for a second opinion. If you have any questions regarding any of these issues, please feel free to contact my office. Thank you.